Meniscal tears. Meniscal injury is the most common knee problem seen in teenagers and active adults. The meniscus can be injured as the result of acute trauma, repetitive injury, gradual degeneration, or any combination of the above. The meniscus are two washer-like cushions found on either side of the knee. The meniscus functions as a shock absorber, both cushioning the knee joint from abrupt loads, as well as spreading out the forces of ambulation over a larger joint area. By reducing joint load in these two ways, the meniscus helps to protect the knee from arthritic change. Unfortunately, once torn, the injured portion of the meniscus loses its protective function. Before going further, it is important to define and distinguish between the terms meniscus and cartilage. It is important to use the words cartilage and meniscus correctly. The meniscus are two washer-shaped rings that cushion the joint and are attached to both sides of the knee. The term cartilage, on the other hand, refers to a smooth, white linoleum-like layer which covers and protects the underlying bone and allows for painless joint motion. Confusion may arise because physicians frequently use the word cartilage to describe the meniscus. For example, when one hears that someone tore his cartilage or had his cartilage removed, what is meant is that person suffered a meniscal tear or underwent a meniscectomy, or removal of the torn meniscal fragment. Cartilage injury actually refers to a progressive wearing away or sudden traumatic damage to the cartilage layer. Cartilage injury by definition is arthritis. Since both meniscal tears and arthritis are all too often found together in painful knees, the correct use of the word cartilage and meniscus is important to avoid confusion. If we cut the meniscus in half, one would recognize that its shape on cross-section is triangular, taller where it attaches to the surrounding knee capsule, and increasingly pointed as it projects into the knee. Placed under a microscope, the meniscus is innervated only where it attaches to the knee. The majority of the inner portion of the meniscus has no nerve endings and therefore cannot appreciate injury or feel pain. One could stick the proverbial fork into this portion of the meniscal ring and no pain would be appreciated. Pain, as you see, only occurs when pulling or traction is placed on the very peripheral aspect of the meniscus, that portion of the meniscus where nerve endings are found. A normal meniscus is depicted in this video clip. Note the washer-like structure is stable and no fragments can be pulled into the joint. In other words, only meniscal tears that result in formation of mobile or loose fragments produce knee pain. These torn meniscal fragments become caught in the rotating joint surfaces and pull against their remaining attachment site with their rich nerve plexus. This meniscal flap tear appears like a windshield wiper, which can be seen being manipulated by the probe. To give you a sense of proportion, the tip of the meniscal probe is only 3 millimeters. This tear, commonly called a bucket handle tear, is another example of an extremely mobile meniscal tear, which when displaced into the joint pulls on the remaining attachment points. The last arthroscopic video depicts a large meniscal tear, which would be readily seen on an MRI. However, since there are no mobile fragments, this tear would be asymptomatic, or in other words, painless, and removing it would not therefore be beneficial. These horizontal cleavage tears are commonly found in arthritic knees. The diagnosis of meniscal injury is made by a history of injury, sudden onset, swelling, and confirmed by an MRI of the knee. It is not unusual, however, for meniscal injuries to present less clearly, without a history of injury and with a gradual rather than acute onset. In summary, not all meniscal tears are painful. Tears without mobile or loose fragments are commonly found in the presence of knee arthritis and are generally asymptomatic. Unfortunately, MRs tell us only what is in the knee and not what's causing the pain. Arthroscopy is an excellent tool for removing a loose meniscal fragment, with generally expected very good results. However, arthroscopic scraping or cleaning up or debridement of arthritis is inconsistent at best and frequently fails to provide relief. In short, arthroscopy has been shown to be an effective treatment for meniscal tears with loose, mobile fragments, but as recent research has emphasized, arthroscopic surgery offers little permanent improvement for individuals with asymptomatic meniscal tears and whose knee pain is secondary to underlying arthritic degeneration. Treatment choices include conservative care or arthroscopic meniscectomy. In this next section, I would like to review these options with you, as well as the success, recovery, and possible complications following arthroscopic surgery. Conservative treatment includes exercise or physical therapy, anti-inflammatory medication, and of course, time. Knee arthroscopy. Arthroscopy is performed with a small telescope about the size of a yellow pencil. Micro-instruments which are used to repair or remove meniscal injury are introduced into the knee through two small incisions called portals. The surgery takes on average 10 to 15 minutes and is performed as an outpatient procedure. Arthroscopy, like any other surgery, has its own risk of complications. Infection may occur in 1 in 500 cases. Deep vein blood clots are said to occur once in every 200 cases and associated with the rare risk of pulmonary embolus. A synovial sinus or passage from the knee to the skin may occur, but these are unusual and almost always heal with time. Lastly, complications of anesthesia or any other general complication of surgery must also be considered. Arthroscopy is performed at Hackensack University Medical Center same-day surgery unit under a general or regional anesthesia. The results of meniscectomy are generally predictable, with good to excellent outcomes in 85 to 90% of cases. However, as previously noted, the presence of arthritis makes the procedure less consistent. Postoperatively, most patients use a cane for 2 to 3 days and begin either a home exercise program or formal physical therapy by the following week. Return to administrative work generally occurs over the next few days, but heavy manual work or athletics will frequently require a period of 4 to 6 weeks to fully recover. If arthritic changes are present, in addition to a painful mobile meniscal tear, recovery may take longer. I hope this presentation has given you insight into the complexity of middle-aged knee problems, so that you can understand your particular knee injury and make educated decisions in regard to present and possible future treatment plans. Following this presentation, I would like to meet with you to discuss the different options available for the treatment of your knee. Thank you.